skeleton. And really, this chapter is about taking that static skeleton, all those bones that we learned, and actually putting it into some degree of motion. The bones, once formed, don't change anymore. So the only way for the skeleton to move is to have the bones move in relation to one another. So a joint is, or an articulation is the proper term for that, is any connection between two bones. That doesn't necessarily mean that that connection has to move, because what we're going to see is that there are three different kinds of joints present in the body, and two of those types don't really move very much. And then the third, the synovial joint, is the one we spend most of our time talking about, and it's a freely mobile joint, or a joint that allows bones to move in relation to one another. So the three main types of joints are the synarthrosis, the amphiarthrosis, and the diarthrosis. Okay, so in a synarthrosis, this is no movement. These are two bones that are joined so tightly together that they do not move in relation to one another. And there are these four different types. So the first is the suture. And these we see in the skull bones, so like where the parietal bones come together and where the frontal and temporal come together and the occipital and temporal and parietal, all of those kind of lock together. Now, in infancy and childhood, the bones of the skull are separate, but by the time children get to be 5 or 6 years of age, those sutures are pretty much locked in place. So that's one type, is the suture. Another type of no movement joint, or synarthrosis, is the gomphosis. This we find where the teeth connect to the jaw. We don't want our teeth moving around. We want the teeth to stay solid in the jaw so the jaw can move the teeth and grind up food. So that's a gomphosis. And its anatomy is basically the teeth are locked into place in the jaw with very tough little threads. When in next semester, when you talk about the oral cavity, you'll see these little threads. But essentially, the teeth are tied into the jaw with these very dense, very tough threads called periodontal ligaments. And then so these are both fibrous. In other words, there are fibers that are attaching the bones together, both in the suture and the gomphosis. There's a cartilaginous type of synarthrosis called a synchondrosis. This is where cartilage connects bone to bone. Probably the easiest place to see this is in the rib cage. The ribs articulate with the spine in the back, but then they come around in the front and they're locked to the sternum with a piece of cartilage. So that's a synchondrosis, a connection through cartilage. And then finally, the synostosis is where two bones that start as, or a bone that starts as two bones literally joins together without any kind of a joint or a connection at all. So like in the suture, even though the bones are locked together, they're still separate. You can see that they're separate. You can very easily pull them apart if you take away the fibers that hold it together. Same thing with the teeth. You can pull a tooth out because those fibers can break. In the synostosis, we have several bones that literally become one bone. So one of the places we see this is in the frontal bones. In infancy, we have two frontal bones, but over the course of development, they join together into one bone. So much so that you can't even tell where the two original bones were. Another place that we've already seen a synostosis is in that coxal bone of the pelvis. Remember, there's the ischium, the ilium, and the pubis, and they form one bone eventually. That's another synostosis. So multiple bones becoming one bone without any visible joint in between. All right. And then another spot, the epiphyseal line. The long bones have that epiphyseal plate where growth occurs. When that epiphyseal plate closes, technically that is also a synostosis, because two bones, the top or the epiphysis and the diaphysis, have joined together to become one bone. So it's sort of a technical point, but that's a synostosis as well. All right, and then we have two kinds of joints that provide a small amount of movement. These are certainly not joints designed or evolved to create a lot of motion. They're supposed to be strong, and they're supposed to hold things very tightly together. So the two types there are the syndesmosis and the symphysis. So in a syndesmosis, this is where two bones are tied together by very tough, very strong ligaments. We see these in a number of different places in the body. So the book's example is the distal articulation of the tibia and fibula. The tibia and fibula at the ankle have to be kept closely or locked together so that they don't spread apart as we walk or run. So there are these very tight bands that hold those two bones together. Probably the best example of a syndesmosis is where the pelvic bones join the sacrum at that sacroiliac joint. Those are some of the strongest ligaments in the body, a ligament being a tissue that connects bone to bone. And that's a good example of a syndesmosis, where bones are tied together by these tough fibers that we call ligaments. And then in a few spots in the body where the two bones come together, there's kind of a fibrous pad in between. So, and we call that a symphysis. So one of those we find in the front of the pelvis where the two pubic bones come together. There's a little tough pad of cartilage, and then there's ligaments that hold those two bones together. Another example of a symphysis is in the intervertebral discs, where you have vertebral body, and a pad in between. Technically, that's also a symphysis. So the symphysis moves a little bit more than the syndesmosis does, but it still is a joint of very little movement. It's all about stability, not about motion. And then the joints that we talk the most about are the diarthroses. These are also called synovial joints, and these are freely mobile. In other words, the bones can very easily move next to each other. So of the three types, it's only the diarthrosis that is freely mobile. So you should know each of these. The three main categories: synarthrosis, no movement; amphiarthrosis, a small bit of movement; and then diarthrosis, free movement, and then the different types of each. All right. So mostly what we talk about is the synovial joints because they come up clinically most often, and they are the most complex. You know, there are several joints in the body, like the knee and the shoulder, that have quite a lot of complexity to them. Anything that's complicated has a tendency to break more easily. So there are lots of problems with the knee. There are lots of problems with the shoulder because we have these complex joints with all kinds of things that can go wrong. But even though each joint is unique, they share some common features. So we can sort of talk about a typical synovial joint and some of its parts and features. So one is the articular cartilage. So at the end of any bone that's part of a joint, we have a area of cartilage where that prevents bone from touching bone. Anytime you have, honest-to-goodness, bone in contact with other bone, that bone is going to wear away. So the synovial cartilage protects the bones that it covers by giving a slick, hard surface for those bones to move next to each other. So in osteoarthritis, for example, which is the arthritis of wear and tear, what happens is this synovial cartilage actually starts to break down. And you start to get into a circumstance where you have bone rubbing against bone. Once that occurs, once this synovial cartilage is gone, the bone literally starts to wear away, and this joint's mobility starts to decrease. So many of you will have heard of people who've had knee replacements or hip replacements. The reason for that is because their articular cartilage has gone away. It got worn away, and once that occurs, the only way to have that joint stay mobile is to replace it with something else. And in those cases, they're done with titanium and plastic. So this here in our picture, this is the articular cartilage. It's very smooth and hard. It really is a lot like plastic. The only difference is, unlike most plastics, synovial cartilage articular cartilage can actually hold a little bit of fluid inside it. So it's a little bit porous compared to, the hard plastic that, it sort of looks like and acts like. So that's the articular cartilage. Inside every joint is synovial fluid. So you can see here's our bone, here's a bone, articular cartilage. All joints have a capsule, so you can see that there's this container around this joint. And then this space here is filled with what's called synovial fluid. And synovial fluid is produced by the synovial membrane, which lines this capsule right here. And it's sort of like an oil. It's very viscous, which means it's sort of thick, but it's also very slippery. So you can think of it as a very heavy motor oil almost. Now it's clear to yellow, and what gives it its characteristics are molecules called proteoglycans, which are complex carbohydrate molecules that hold water next to them all the time. So the synovial fluid it lubricates the joint, and it also provides some shock absorption. So that synovial fluid is produced by that membrane. There's only a small amount in there. Even though like the knee is a great big joint, the amount of space that's actually inside that capsule is very small. So like in the knee, there's only about 3 mLs of synovial fluid present in that giant joint. So you don't need very much for it to accomplish its primary functions, which we're going to go over. All right. So one is lubrication. Generally speaking, if you're going to slide two things next to each other, you want to have a thin layer of liquid in between so that it will slide very easily. And synovial fluid provides that function. It is absorbed into the articular cartilage. It fills the space, this tiny little space where the two articular cartilages come together. So not only does the articular cartilage protect the bone, but with synovial fluid, even the articular cartilage doesn't actually rub against each other. Instead, it rubs on this thin fluid that gets sort of mashed in between the two. So it makes the joint move very easily. All right. So lubrication is one. Nutrient distribution. At the ends of bones here, the blood supply to this area is not the greatest. Most of the blood is up here, and by the time you get to the articular cartilage, the circulation is not very good. So in order to keep the articular cartilages healthy and the inside of the joint healthy, you need nutrients. You've got to get nutrients in and waste products out. And so for these areas, the synovial fluid kind of functions like blood in those areas. It provides nutrients to the articular cartilage as well as the distal ends of these bones here. And because synovial fluid is always being created and reabsorbed, there's a flow of nutrients in and waste products out of the joint. So it's important for that reason. And as we move our joints around, that synovial fluid gets moved around too. So it helps, there's no circulatory system in there, but one of the reasons it's better to stay active than inactive is because it keeps that circulation going for the synovial fluid. All right. And then the last purpose of this fluid is shock absorption. Anytime you take a force and you put it into a liquid, it has a tendency to disperse energy. And the reason for that is a fluid will disperse energy equivalently to all of the surface that it can. So the synovial fluid acts as kind of a shock absorber in the body, particularly in the knees and hips and ankle. So like when you're jogging, for example, and all your weight falls on that one foot, we don't get a jarring force up into our skeleton because of all these shock absorption along the way. So the fibula helps with that, but then so does the synovial fluid in the knee and hip. It helps to dampen out that force that's coming up into the leg. All right, so synovial fluid is found in the joint space here. And then we have some other features that are common across multiple joints. As you'll see when we start getting into the specific joints, joints are complicated three-dimensional structures. You know, you've got a three-dimensional bone connecting to another three-dimensional bone, and everything's in motion. You know, there's movement that's going on there. So, in addition to the articular cartilages, which are attached to the bones, many joints also have accessory cartilages that help to keep the joint in its proper alignment while still allowing lots of motion. So, for example, when we get to the knee, we're going to talk about the menisci. That's plural of meniscus. And in our picture here, this would be one of the menisci here. So it's not connected to the bones, but it helps to keep the bones lined up straight. And many joints, particularly the more complicated ones, will have some of these extra cartilages. Now, usually they're of the hyaline variety, so it's hyaline cartilage, which has that kind of flexible, plastic-like character to it. All right. Many joints will have a fat pad. Anytime the body has to fill a space that there's nothing else to fill it with, it uses adipose tissue to fill that space. You know, so just like packing a Christmas present to ship somewhere, you want to make sure that all the space is filled up, so that object doesn't crash into the side and get broken. Essentially, the fat pads do that same thing. So like here in the knee, you can see there's a big one right here. So when the knee is straight, this fat pad is in this shape. But if you can imagine in your mind that the tibia that now bends over this way, like a bended knee, that fat pad is going to change shape, right? But because fat is very flexible and semi-fluid, it can change shape very easily. So anytime there's a space to fill or an area that has to change shape, the body is likely to have a fat pad there. So we have fat pads in our elbow, we have them in our shoulder, we have them in our knee, we have them in our hip. So it's packing. It sort of fills that space. All right. And then ligaments. Ligaments, by definition, attach bone to bone. So this is fibrous tissue that attaches bone to bone. Not to be confused with tendon, which connects muscle to bone. So ligament is bone to bone, tendon is muscle to bone. All right. And in all joints, there are ligaments that attach the bones together. Now, they attach in such a way that the bones can still freely move, but it's not just the muscles that hold the skeleton together. The skeleton has its own infrastructure, it holds itself together through these ligaments. So they're kind of strap-like. So like here in our picture, here's a ligament at the back, and then here, oh, that's a tendon. But here's another ligament here in the front. So ligaments are bone-to-bone connections. All right. And then tendons. Joints don't move themselves. The joints have to be moved. The muscle or the bones of the joint have to be moved by the muscles that are crossing that joint. So a tendon is a connection between muscle and bone. And technically speaking, the tendon is not part of the joint. The joint is made up of the joint capsule, the synovial fluid inside, the articular cartilages, and then the ligaments attaching bone to bone. But tendons play a major role in the stability of a lot of joints. So the shoulder, for example, is very much stabilized more by tendons than by ligaments. And to some extent, we see that same thing happening in the hip, too. So tendons are an integral part of the joint, even though technically they are outside of the joint. They cross that joint. All right. And then one you may never have heard of is called a bursa. A bursa is simply a fluid-filled sac, okay? And the fluid that's found in there is very much like synovial fluid because it's produced by the same kinds of cells that produce synovial fluid. That's that synovial membrane. Now, the reason for this is where the joints have to, where some part of the joint has to rub up against another part of the joint, that would cause friction. So let's see. Let's pick one. Okay, so for example, here's a bursa. They're in green in our picture here. And remember, we're looking at this in cross-section. So this area, it would almost be like a flat balloon that's been, a thin, flat balloon. Well, this tendon right here from the quadriceps, it's going to have to rub up against the tibia here. So by having this fluid-filled sac, it takes that, what would have caused friction, and makes it nice and smooth. So bursae, which is the plural of bursa, are fluid-filled sacs that are found between elements of a joint where things have to move across each other. Now, the reason you may have heard this word before is bursitis is an inflammation of the bursa. And because we have bursa in practically all of our big joints, you can get bursitis in a number of different ways. So like tennis elbow, for example, is a bursitis. And the reason for that is, if you've been playing a lot of tennis, the bursa have really gotten a workout. They have been doing their job of reducing friction, but they themselves have gotten rubbed and rubbed and rubbed, and then they start to get inflamed and irritated and start to cause pain. So bursa, usually nobody thinks about them until they start to act up, but they are important aspects of the joint that help to keep things moving nice and smoothly. All right. Bursa also play a role in shock absorption too. Any fluid-filled space is going to play a role in shock absorption just because of how fluids disperse energy as they come into them. And your book picked the knee here because the knee is probably the most complicated of all the joints, and it has all of these different features. So it has multiple bursa, it has multiple fat pads, it has accessory cartilages. So they're not all this bad, but just generally speaking, those are sort of the parts of the joint. All right. So just to review, we've got our bone here. Here is the articular cartilage firmly attached to the epiphyses of each bone. We have some accessory cartilages in here that are helping the two bones to stay in alignment. Here's our synovial membrane, which creates the joint cavity. In here, we would find that synovial fluid, thick, viscous, slippery stuff. And then we have ligaments and bursae. All right. So we'll see some more details when we get into the specific joints. All right. So our first question of the day: when two bones grow together across a joint to form a single bone, what do we call that? You have to give me a second to send it to you. All right. All right, jump in there, last few people. All right, so that would be D. A synarthrosis is where more than one bone has literally become one solid bone. So there is no longer a joint in that bone. They have grown together into one bone. So the frontal bones are an example there, and then the coxal bones that start out as three bones that become one bone. The suture is a fibrous connection that we find in the skull. The gomphosis is what holds the teeth into the jaw. And then the symphysis is where two bones come together and they have kind of a fibrous pad in between them. But that's an amphiarthrosis. It doesn't move very much. All right. So which of these things is true about articular cartilage? All right, so articular cartilage is what covers the ends of bones inside synovial joints. It's very slick, it's very hard, and it allows bones to move next to each other with very little friction, particularly when you put some synovial fluid in there too. So just like the oil in your car keeps everything running nice and smoothly, the articular cartilage and the synovial fluid in the joints keep that joint moving nice and smoothly. All right, what's a bursa for? All right, you guys answered that one fast, so you can go ahead. That's B, a fluid-filled cushion. That's all a bursa is. Anatomically, like in the cadaver or in surgery, it's actually hard to find the bursa because they're very thin-walled and they literally blend in with everything else. So they are discrete anatomical structures, but they're sort of hard to identify and assess. All right. So we have multiple different kinds of joints, and one of the ways that we have to consider how they're different is the ways in which they can move, okay? And we call an axis is a way in which something can move. So it's a little bit broader of a definition than we're used to with axis. You know, usually we think a thing that has an axis can turn on that axis, right? Well, we're using a larger definition, and an axis is a way that a thing can move, so a type of motion. So we can use a pencil to describe a number of these different types of motion. So, you know, a stationary pencil, 90 degrees to a piece of paper, that's sort of like a synarthrosis or a syndesmosis. It doesn't really move. We can take that pencil and we can move it across the paper. That's a gliding motion or a linear motion. We see that kind of motion in like the wrists and ankles. We can hold the point stationary and we can move the pencil around. That's angular motion, and we see that at the hip and at the shoulder, that ball and socket type motion. In circumduction, we can hold that pencil point in place and we can draw a circle with the eraser in the air. It's actually a special type of angular motion, but there again, we see that with our ball and socket joints in a motion like that. And then finally, we can rotate the pencil. So we would call that rotation. And the different axes or the different joints have one or more of these types of motion related to them. So we can classify joints by the number of ways in which they can move. So like you can have a monaxial joint that can only do one of those things. So like the atlas on the axis, the head shaking the head left and right, that's just one range of motion or one axis. All right. And then we can have, bi or tri or multi-axial. So we have 6 main types of synovial joints. The first is a gliding joint. So this is where, just like our pencil on the piece of paper, the bones slide against each other. So we find these where the clavicle meets the sternum. There's a gliding joint there. We see these in the wrists and ankles. So intercarpal and intertarsal, that means between the wrists and between the ankle bones. And then at the vertebrocostal joint, so where the rib attaches to the vertebrae, there's a sliding motion that occurs there as we breathe, as the ribs go up and out. All right, so that's a gliding joint. Probably the simplest kind of joint is the next one, the hinge. This is a monaxial joint because it can only move in one direction. Just like the hinge of a door, it can open and it can close, and that's it. So we have, these are typically the strongest joints in the body. That's elbow, knee, ankle. What they're talking about is where the ankle articulates with the tibia and fibula. And then the interphalangeal joint, so where your fingers bend, those are hinge joints. They can't really do anything else but get bigger and smaller. All right. A pivot joint, there aren't very many of these, but this is where there's rotation on an axis. So the best example is the atlas on top of the axis is a rotational joint because we can move our heads from side to side. Another cool place we see this is in the elbow, where the radius and the ulna join together. I've got a cool video that I'm going to show you next time about how that radius turns or pivots in its joint that allows us to turn our hands up. All right. An ellipsoid joint, this one's a little harder to visualize, I think, but where the first or the proximal phalanges joins the first metacarpal, so the first knuckle of your finger, is an ellipsoid joint. What does that mean? It means we can spread our fingers as well as bend them, and these ellipsoid joints, they allow a little bit of that motion, similar to the saddle joint. Sorry, the one I just described, phalangeal metacarpal, it's a saddle joint, but it's similar to this ellipsoid. So we have a rocking motion that's possible, as well as a bending for the saddle joint. And then the last one is the ball and socket joint. And this we see in the shoulder and the hip. And the cool thing about this pattern in a joint is it's both strong and flexible. You know, if you look at the hip has this great big ball in an almost complete socket. So we have a lot of stability, yet we can still move in multiple axes at once. So ball and socket joint, shoulder and hip. All right. Okay. And then our last topic for today is, I have to get up my soapbox a little bit. Everything I try to teach you anyway, I think has some importance, right? Because it's going to help you understand the body, it's going to help you take care of patients, all that stuff. This next little section about describing movement is one of the most important things to get out of this whole course, okay? Because these are words that everybody in taking care of patients use to describe how the body moves. You know, it's not good enough to chart cannot bend elbow, okay? You have to use the right words and describe it because there's a lot more you can describe than can't bend the elbow. You know, limited flexion, limited extension, those kinds of things. So this stuff we're going to go through now and then we're going to do it again on Wednesday is just really critical for you to know. So practice it. You know, what we're going to describe here is all of the ways your body can move. So at home, go through each of your joints and describe for yourself in the words we're about to learn the motion of that joint, because this is all really important stuff. Whoops, I went way too far. Hold on. All that big lead in and then. Okay. Try this again. All right. So first up, flexion and extension. Flexion is the reduction of an angle between two bones. All right, so what does that mean? All right, if you've got a bone here, and you've got a joint, you've got another bone here. If this angle, this is the angle we're talking about. If we are reducing that angle, that's flexion. Another way to think of it is unstraightening. If you're unstraightening a joint, you're flexing it. So, for example, when we go from a straight arm to a bent arm, that's flexion because we're reducing the angle between those two bones. Extension is the opposite. Extension is increasing that angle up to 180 degrees. Okay, so flexion is less than 180 degrees. Extension is up to 180 degrees. Now, in some of our joints, we can go past that, and that's called hyperextension. So if this is 180 degrees, if we then bend that further back, well, now we'd be at 200. That's hyperextension. So places we can do that at the hip, and we can do that at the head. So like you can point your leg behind you, that's hyperextension, because this is extension 180 degrees at the hip. So if you can go opposite that, that's hyperextension. We can also do that with the head. We can flex the head and extend the head. We can also look at the ceiling, which is hyperextension, greater than 180 degrees. So just looking at that in pictures, flexion of the head, extension, hyperextension. At the elbow, that one's probably the easiest, flexion and extension. And we can't really hyperextend very much at the elbow. Some people can a little bit. At the knee, it's flexion and extension. The hip is a little harder, I think, for people to conceptualize, but kicking a ball is flexion at the hip, because the angle you're looking at here is trunk and leg. So if you're reducing the angle between the trunk and the leg, you're kicking, or that's flexion. And then extension is straight leg, hyperextension is behind you. So when we walk forward, we flex the hip, we plant the foot, and then we hyperextend a bit to propel us forward. All right, so flexion and extension. At the shoulder, it's also a little counterintuitive, but I've got a little video to show you on the shoulder that'll show it a little easier. All right, and then some others. Lateral flexion. Typically when we're talking about flexion, we're talking about in a joint's normal range of motion, the common range of motion. But like for the head and the trunk, we can actually bend them to the side. We call that lateral flexion. So you can do that with your trunk, and you can do that with your head. And then when we get to the ankle, for whatever reason, it gets a special name. Plantar flexion is pointing down towards the plant or towards the bottom of the foot. Dorsiflexion is pointing your toes up to the ceiling. So they're both flexions. And probably the way that came about is it's confusing to think flexion and extension at the ankle because of the natural bend that's present at the ankle all the time. So we use these different words instead. Plantar flexion is towards the ground. Dorsiflexion is toes towards the ceiling. All right. Some lateral directions. We have abduction and adduction. Abduction is to pull away from the midline. So like to pull the arm up and out, that's abduction. And then adduction is to bring it back down. Now here are two very unfortunate words, right? Because they sound practically the same, right? So it is very common, and no one will fault you for doing this. It doesn't make you sound silly, it makes you sound smart. A lot of people will say the letters. So it's abduction and adduction. Why? Because those words sound very similar when you're talking. So you will hear people call it abduction or adduction just to avoid the confusion. So we can abduct the arms, the legs, and then we can also abduct the wrist as well as the fingers. So abduct is to take away, adduct is to add back. So we have abduction, pull away from the midline, adduction, come back in. And then in the hand, we can also abduct the fingers. So if you spread your fingers out, that's abduction. If you pull them back together again, that's adduction. All right. And then the shoulder and hip have this special movement called circumduction. And basically what that means is we can draw a circle in the air with both our legs, with our toes, and with our fingers. And what that does is it describes a range of motion of the shoulder and of the hip. That ball and socket joint can go all the way around its socket, essentially. So we call that circumduction. All right. Some others, rotation. Just like the head shaking no, this is movement on its own long axis. And it's not just the head that can do that. In the hips and shoulders, we have both internal and external rotation. So here's what I mean by that. If you bend your arm like that, you can move in this direction. So you can move your hand down and up. But the only thing that's moving is your humerus. And your humerus is literally rotating to bring that arm up and down. And you can do the same thing with the femur. It can rotate. So internal rotation is a rotation towards the inside of the body. External rotation is rotation out or away from the body. So we have internal and external rotation. At the forearm, because we have those two bones that can cross or uncross, we have pronation and supination. Okay, so to pronate is to put the palms down. To supinate is to put the palms up. So an old mnemonic is you hold sup, that's supination. So palms up is supination. And then palms down is pronation. And what's happening there is in supination, the forearm bones are parallel, so the palms are up. In pronation, the forearm bones are actually crossed, so the palms point down. All right. So internal and external rotation. You'll also hear that called lateral and medial rotation, which sort of makes sense. When you laterally rotate, your hand is going lateral. It's going away from the body. Medially rotating, your hand is coming in towards the body. For the head, it's just left and right rotation. And then for the forearm, it's pronation and supination. All right. And then some special ones. The ankle, not only can the ankle plantar flex and dorsiflex, but it can also evert and invert. So what we mean by that is you can point your toes, or you can point the the sole of your foot off to the side laterally. That's an eversion, and an inversion is the opposite. So the ankle has to be able to move separate or move in that direction so that we can walk on uneven terrain. So like when you're walking up a hill, if you're on a hill and you're walking along, the slope of the hill is like this, but you're walking this way, one of your feet will be everted and the other will be inverted so that you can stay upright while you're walking on a hill. So eversion and inversion are at the ankle. We already talked about plantar and dorsiflexion. Opposition. As an advanced primate, our thumbs can come across our hand. We call that opposable or opposition. So when you touch your thumb to your pinky, that's opposition. It allows us to grasp things much more easily than some of the lower primates. The jaw is very flexible. You can push your bottom, or you can take the jaw and push it forward. You can actually, and pull it backwards. And then you can open it and close it. So retraction is to pull the jaw in towards the neck. Protraction is to stick the jaw out. Depression is to lower the jaw, and then elevation is to raise the jaw. The jaw can also move laterally too. You can throw your jaw out to the left or right as well, which would be a lateral or left or right deviation. All right. And then we already talked about lateral flexion at the ankle or at the neck and the trunk. All right. Okay, so the shoulder, which I think is going to be our last topic of the day here. Okay. So movements at the shoulder are somewhat counterintuitive. Okay, so that is flexion. So raising the arm up is flexion. Bringing the arm back down is extension. And we can hyperextend, because we can, bring our arm back. This one's easy. Abduction and adduction. So bring up and out or down and over. There's horizontal abduction and adduction, because we can move the arm like that. And then we have our rotation. So we have internal rotation and external rotation. That humerus can spin in its socket and move the hand up and out. The one that's probably least intuitive is that whole flexion extension business. So in neutral position, hands down, that's fully extended. So any departure from that is flexion or hyperextension. Because the angle that's being looked at there is the angle of the shoulder with the trunk. So here it's 180 degrees, and then you start to go up, and that's flexion. All right. Okay, let's do a question before we get done here. All right, standing on one's toes is an example of a movement called which of those? So remember to bring your book to lab, and homework's due tonight by midnight. All right, jump in there, last person. All right, there we go. Okay, so standing on one's toes, that is plantar flexion. Standing on one's heels, that's dorsiflexion. All right, so be sure you go over these motion words. We're going to hit them again on Wednesday, answer some more questions about them. But this is must-know, have-to-know material, just so you don't look not smart out there in the world of taking care of patients. All right, that's it for today.